Good morning, everybody. It's great to be with you. And we're at both, I think, a substantive moment in healthcare and also a political moment. There's a lot going on, and we have been watching. We have Senator Cassidy here in a little bit, well, at least on video, and I have all the stuff that he was talking about. I want to just start out doing something we've done in some Atlantic events, because the Atlantic is supposed to be a place that provokes thinking, gets people out of their comfort zone. And I'm going to pick on my two wing men. I'll come to the middle in a moment. And just ask each of you for a moment, because Avik, I know you have been a big critic of the Affordable Care Act. You've been probably the most manic, obsessive, compulsive person I've seen to put something perhaps better, perhaps different on the table.
I'm not feeling very manic at the moment.
You will. And you've been a critic, but you've gone forward and said, hey, here's a better alternative. And I knew you have been the one who set up a system here in Massachusetts, an exchange, and early under Governor Romney, that was held up as the model for Obamacare. So I take it you supported the Affordable Care Act, correct? Right? So I'd like to ask you to switch places, not literally, but at least intellectually and mentally, to argue what is the best feature of Obamacare, Avik, that you think deserves at least praise or ought to be continued as we think forward. And I'm going to ask you to tell us what you think was the biggest failing thus far of Obamacare. But let's just start right there.
Yeah, I would say that the most important reform that we need in our healthcare system is for more people to buy health insurance directly rather than getting it from their employer or the government. Mm-hmm. Because when people have that control over their healthcare dollars, there's much more accountability up and down the healthcare system for the value and the quality that healthcare provides. And so I think the best thing about the ACA is that it tried in part to move us in that direction, to create a system where more people were buying health insurance on their own than had been before. Now, that leads to why I've been such a critic of the law, because I think while it did that very important job of encouraging more people to buy health insurance on their own, it created a market that drove up the cost of that health insurance for a lot of people who otherwise can't afford it.
So, John?
What's the question?
What's
wrong with Obamacare?
Yeah, what are the biggest failures of Obamacare, or even the great work you did here in Massachusetts?
Yeah, the biggest, nothing in Massachusetts went wrong. The biggest failure is its very daunting complexity. We took the world's most convoluted healthcare financing system that had been layered on decade after decade for 60 years, actually 80 years going back to the Depression, and we quintupled its complexity. So nobody can understand it. Mm-hmm. If the Republican plan in the House kept the funding, mm-hmm. instead of giving it to rich people as a tax cut, there's actually a lot in that plan that would simplify and make Obamacare better. So there are a lot of details. I'll just give you one example. We use these very simple medal levels. We stole them from the Olympics, bronze, silver, and gold, to make it kind of obvious to people that they were buying a less or a richer coverage. First, the feds added platinum, which of course is not in the Olympics. Then they added three more levels of subsidy. But instead of using any of the four that they already created, they created three more that had to be retrospectively settled with insurance companies after the year. So that now there are literally 8 levels, and nobody pays any attention to the medal levels anymore. So this consumer decision support tool was complexified, there is no such word, to the extent that it's useless. And there's dozens and dozens of examples like that.
Audrey, and one of the things I've noticed in this debate, and we have so many different stakeholders in the health equation here in this room today, watching online, thinking about this, and you've been in this for forever, is that it looks as if, I don't know how to put this, rationality isn't necessarily the guide. It's competing interests, might makes right, who can force something through. There's enormous complexity. But I want to give you all the power in the world for a moment. What are the principles that most matter? What should all of the stakeholders just simply agree to get to a better healthcare place?
I think I would say the principles that we would need to agree to are, number one, that everyone needs coverage. That it's really not just that people do better with coverage than when they're uninsured, but having everyone with coverage gives you
just as a data point for just keeping us, how many people do not have coverage in the United States today?
I actually don't have the exact number, I'm sorry.
Avik, do you know?
It's about 30 million.
30
plus or
million.
Yeah,
minus.
so.
I just wanted to raise that
Yeah,
as
and
a,
in
as a
here,
target.
we're in, part of my not focusing on that is that I'm lucky enough to be in the state with the best coverage, with a very small percent of people without coverage. So it's also gives you a platform to do a lot of other things to improve the healthcare system. So then, on top of that, I think in thinking about some of the flaws in our system today, we really have to change the delivery system model and the payment model to go along with that. So, there's a lot of efforts underway across the country to, move away from fee-for-service, get into value-based payment. And then finally, I would say
But the system, but the Affordable Care Act has been pushing that.
Right.
What happens if there's a whiplash back another direction?
Well, I think the whiplash historically has been around the concern that there's an incentive to withdraw services. And most models that I'm aware of today really put just as much of an emphasis on quality metrics as they do on the savings. And in fact, many of the provider groups that are participating in these new models can make more money earlier by meeting the quality metrics than the harder work of getting the waste out of the system. So you're right. It's in the past, in the 90s, managed care, lots of pushback, but I think these models are pretty different. And then I think, another really hard thing that we have to tackle now is the recognition that what's involved in keeping people healthy and getting people healthy only has a small amount to do with what happens in the clinical system. And a lot of it has to do with just the issues of poverty. Our focus is more on low-income populations. So it's housing, it's food, it's all the things that make it hard to focus on your health.
Alan, you call yourself the chief geek at Oscar Health, and you were founded in 2012. Do I have that right?
Yes.
And so why would anyone go into this convulsive, turbulent, unknown, unpredictable future of healthcare? I mean, in the sense that you built this business. I'm interested in what you saw as the opportunities and what the challenges have been in the state of healthcare provision in the country today.
There are a couple of key points. One, tying back to what Avik was saying, if you empower the members, the patients themselves, if you make things more visible to them, they'll start driving a market in a better direction. So we started off focusing on the members, the patients, and their experience. First of all, it's just flat. I'm sorry, we're busted. The experience for consumers today in dealing with the complexity in the healthcare system, from picking a plan and figuring out what kind of coverage, to even understanding what their plans mean, what deductibles are in and out of network, all of that is enormously complex. And so they basically pull back and the system just deals with them rather than vice versa. So we started off with the premise of empowering those members and putting information in front of them, explaining what's going on, and enabling them to make choices from the first time when they come in to sign up for their plans, when they first get introduced to Oscar, to getting introduced to their concierge team and having conversations around what their current medical situation is, what needs they have, what doctors they need for particular conditions, and so forth. So our whole drive is around building that connection between our members.
Do you track personal stories? Are you yourself in touch with sort of human stories in your place? And how does somebody's sense of possibility change? Have you been looking at that when you do this more individualized tracking?
From my background, tracking is a bad word. I was at Google for a number of years, and there's a lot of sensitivity around what you keep hold of. But we do pay a lot of attention to how our members engage and what that means for their behavior. One of the things we launched early on was step tracking. Very simple, add to our mobile app. It plugs into Google Fit or whatever fitness app that you happen to have. And we put something in the app that gave them a target daily and gave them a reason to come back and connect with the app.
Yeah, right? I don't know if I'm on your app, but this is my Fitbit.
And you look at how that engagement and them starting to connect with us on a daily basis changes other behaviors. If you look at their use of telemedicine,
right?
Okay, telemedicine use is something we're all really excited about. It has an opportunity to reduce costs enormously, handle a huge fraction of all the conditions and situations our members go through, but you have to get them to actually use it. Typical engagement rates when companies or when plans push this out are 2 or 3% across their population will engage with it. Across our entire population, we get 23% of our members are actually using telemedicine in lieu of going for an in-person visit. And if you slice that and look at the members that are also engaged with step tracking, so they're more connected with Oscar and more thinking about us, those numbers go up into the upper 30s. So we're getting those kinds of numbers on people using these new technologies, these new capabilities, and it gives us an opportunity to connect with them and get them to the right level of care at the right time.
Avik, you've been out there trying to craft something, and I've read your Transcending Obamacare material, the short form, and thank you so much for the short form. There's a very long
it's 102 pages,
version that folks can indulge, but it's a very interesting proposal, and you purport to have a plan that will cover 12 million more Americans. So that would get to, than Obamacare did. So that would get us sort of in the whole process here about a net, 37 million more if you were to look at it. What are the biggest transition issues that you want to change? Because what you wrote a piece that I found fascinating where you looked at the kind of existing Republican plan, the Obamacare plan, and what Transcending Obamacare does. And I'm interested because it seems very pragmatic. I know you're a conservative, and I know you want this to be the plan of the Republican Party and maybe the country. But what are the biggest transition junctures? And you're a political observer. How's it going?
Yeah, so all that matters. So at first you have to have an endpoint. What are you looking to achieve? And I think my argument to conservatives and non-conservatives has been there's enough money we're spending on healthcare in this country to cover everybody. We don't need to actually spend more. If you actually look at just public or government spending on healthcare in the United States per capita, we all know
that's about $3 trillion.
Yeah, well, the total is $3 trillion, private and public. We all know the statistics about how we're spending 19% of GDP, and we have all these uninsured and all these things. What I'm talking about specifically is the public portion of that overall spending. The public portion of our overall spending on healthcare in the United States is about $400 to $4,200 per person, which is more, just the public spending piece, than almost every other country in the world. There are only 2 other countries, and that's pre-ACA, that were spending more than us. All that to say that, there's a perception on the right that, well, we can't have universal coverage because that would require more government spending, more intrusiveness than we have today. And my argument, my case, but actually that's not true. If we actually changed the incentives in the system and subsidized lower-income people more, help them more, right now we spend a lot of money subsidizing upper-income people in our healthcare system. If we switched that around, and it would be a gradual transition over time, you could have a system that covered everybody and spent less money. And so it achieves both traditional progressive goals and traditional conservative goals at the same time. And the model for this in Transcending Obamacare is the Swiss system, which the Massachusetts system also borrowed from. I mean, the original idea behind exchanges really comes from there, where what they do in Switzerland is there's a sliding scale of subsidies where if you're really poor, you get the premiums fully covered, and as you go up the income scale, the amount of dollar assistance you get goes down and phases out. And the way it works in Switzerland is that's the only system there is. Imagine if we had an American healthcare system where the only thing that existed was the Obamacare exchanges. There was no Medicare, there was no Medicaid, there was just the exchanges. That's basically what Switzerland does, plus or minus. I'm oversimplifying to a degree. So the idea behind Transcending Obamacare is to learn from the Swiss model, which has worked very well for Switzerland, is very popular and has broad public support there as a way of saying, hey, a way we can save money here is, again, to reallocate our subsidies gradually over time towards the people who really need the help, lower-income people, vulnerable people, sick people, and spend less subsidizing upper-income people. If we do that, we'll reduce the overall footprint of the government.
This is sort of a Rockefeller Republican approach.
Well,
you got Rick Perry and Marco Rubio to pair.
I think it appeals to a broad cross-section of people. It appeals to people who want to make sure that everyone has health insurance. It appeals to limited government conservatives who want to reduce how much we're spending on healthcare, who want to solve the entitlement problems and the $47 trillion in unfunded liabilities that our Medicare and Medicaid programs have today. That's what's attractive about this system. And so you ask the question of where is Washington right now relative to this theoretical idea. And I'm actually fairly encouraged by what I'm seeing in the Senate side of this. I think the House process was limited because the Speaker, Paul Ryan, specifically felt that it was wrong to direct more assistance to lower-income people. He believes that you have to give the same assistance to everybody because if you don't, as you make more money, you're discouraged from making more money because
so they were against means testing.
Paul Ryan specifically was. There were a lot of people in the House who supported a more means-tested approach, but the Speaker has more sway, and so his view won out in the end. But I think in the Senate, there's, as you'll hear from Senator Cassidy, I think there's much more of an interest in having much more of that means-tested Swiss-style approach. And we'll see what the legislative text looks like in a week or two, but I'm optimistic that it will look a lot better than what we saw.
Audrey, you seem to want
Yeah, I wanted to just add that there's another reallocation that I think we can learn from looking internationally, which is that, excuse me, as Avik said, we spend so much more on medical care than other countries, and our outcomes are sort of, in the middle. But the big difference is other countries spend much more compared to on social services compared to medical care, and the countries that have the best health outcomes actually have, sort of the opposite of what we have. Spending a lot more on issues like poverty, homelessness, all that, and less on healthcare. So I do agree that there's a lot of opportunities for reallocation.
John?
At the broader financial level.
Actually, I would agree with Avik that Switzerland might be a better extension. And fortunately, there are many other models out there that work quite well. The problem with that kind of proposal and with the reallocation is this is America's largest business, and so it's not just reallocation. When you say reallocation from subsidies from the rich to the poor, that's on the beneficiary side, I think you're thinking. But it's really on the provider, insurer, supplier side that we need a reallocation. We actually know how to cut our costs down to the level of other OECD countries. They all use fee schedules. We have this market approach that lets providers, whether they're pharmacy producers or clinicians or hospitals, charge literally 2 to 3 times as much as Medicare or anywhere else in the world, or they're competing next door provider neighbor for exactly the same service.
I just got to vigorously disagree with one thing. That's not a market-based approach. I would call that crony capitalism. The fact that
crony capitalism.
I think crony capitalism is a great word for it.
Drug companies can charge whatever they want, or hospitals can charge whatever they want, doctors can charge. That's not a market. In a market, patients would hold people accountable for the price they charge. They're able to charge those prices because they don't see the prices themselves. They're paid for by third and fourth parties.
Unfortunately, we don't actually have that kind of market anywhere in the world.
Let me ask you perhaps a naive question, because in the years that I've been doing health events with lots of parts of the ecosystem, from the drug companies to providers to insurers to everyone, I have seen a lot of transitions. When you get change, you get different winners and different losers, and you see adjustments. So I see fewer hospital beds in the country. I see more outpatient care. You see more discussion and models of value-based pricing of drugs and pharmaceuticals. You see more focused on outcome-based medicine, et cetera. And I'm interested, so you do seem to be getting some of the shakeup in the system between all of, a new equilibrium between them that seems to be, you seem to be wanting to move it more or very dissatisfied with what. But I'm just wondering maybe we haven't had enough data, but from wellness programs, from trying to think about other parts of the health equation, that seems to at least have entered the discourse far more than it used to be, at least in my own subjective experience. So what am I missing in this crony capitalism model that you just talked about? Because it seems to me that I do see some positive things going on.
Yeah, so I mean, one thing you'll hear, and you may hear a lot today, is one of the big buzz phrases in healthcare policy is delivery system reform. You hear a lot of people talk about, well, we've got to make healthcare more efficient. We've got to make sure that people are getting in and out of the hospital faster, et cetera. So we're eliminating unnecessary care. All that's good, right? From a public health standpoint, it's good to eliminate unnecessary care, move, as people say, from volume to value. All that is wonderful. But that's not the reason why healthcare is so expensive in America. Actually, in 2010, so 7 years ago, if you look at OECD data, the average length of stay in a non-American advanced industrialized country hospital was about 8 days. In America, it was 5 days. So we were already doing a much more efficient job than every other country in getting people in and out of the hospital faster to reduce costs. The problem is the average day in the hospital costs 5 times as much. And the reason the average day in the hospital costs 5 times as much is not because we're doing 5 times as much stuff to the patient. It's because the MRI price is 5 times higher. The CPAP respirator price is 5 times higher. So it's ultimately, Uwe Reinhardt of Princeton wrote a great article about this 20 years ago called "It's the Price is Stupid." Yeah. And it's all about price. And this is the fundamental problem with our system, and this is the thing that providers have been very resistant to change.
Alan, I'm going to ask you the sort of big concept question here, because one of the questions I have about this debate is whether there's a bank shot out there that we're not paying attention to, that we're sort of blind to the notion that, you were just talking about individual-based care. There's precision medicine coming on. There are sensors that are going to be watching everything we do, interacting with our daily lives. I just saw a rug that Intel has developed. It's not for sale yet, but that Intel has. If you walk across, it gets to know you. It can tell you if you're going to have a stroke. I mean, there are these things that are going to be happening. I don't know what you do with that, but nonetheless, it's interesting that the other side of this is a fascinating revolution in genetics. In Avik, I know you've been an investor in a lot of this newer. How much of the next world will somehow change this debate so dramatically that this will seem silly in 10 years?
I'm actually with Avik again here in that I think all these efficiencies and these being able to model and understand someone's health history in such detailed fashion, you can predict what's going to come and where you should intervene,
right,
and what kind of monitoring you need. Those things are all going to help a lot, but I keep coming back to incentives. First of all, we've disabled the incentive on the patient, the consumer's side, by putting this wall up. They can't see what's going on.
Right.
So first of all, you have to break that wall down.
So transparency is key.
Transparency is key.
And you all agree? Transparency?
Yeah, but it has to be accessible. It has to be something that people can understand.
John is not a fan of transparency.
Oh, it's hard to be against. I like sleep. I like food. I like air you can breathe. Sure, I love transparency, but by itself, it's going to get us nowhere.
No, it's a great thing.
By itself,
yeah.
you're absolutely right.
Yeah.
It's not enough. We have to work on the incentives driving the other part, the cost side of the system. And what we've done with that is look for specific providers, networks, hospital systems that are interested in not just talking about population health and these new approaches and stuff, but they actually want to work on it and do the integrations and put in place functionality that works from the member back through the entire care system to take care of those patients and get them to the right level of care at the right point in time and work towards outcomes rather than towards a fee for service.
Go ahead, John.
Well, you asked about a bank shot. It's actually impolite to talk about the solution to healthcare costs in this country because it means we all take less money. And that's just an impolite conversation. But there is something that people can get around, they love it, which is patient safety.
Right.
If it were categorized as a cause of death, hospitalization would be the third highest cause of death in the United States. There is huge amounts of savings and improvement in care, and clinicians actually want to practice more safely. So I think IT and artificial intelligence can make a huge difference there without having to swim upstream against all the financial incentives. The problem I see with it is we're going to get to the point where a lot of really intelligent, highly trained physicians can be replaced by artificial intelligence. That is, you'll always need radiologists, but 90% of what they can do can be done by a computer 10 or 15 years from now. And will they be focused on patient safety, or will they be focused on preserving their jobs? The history tells us.
And what do you think? Well, I mean, isn't that sort of happening now?
It's beginning to happen now, yeah, but we're very early on, very early.
Let me ask you just.
I'll actually take exception to that. The artificial intelligence, machine learning, what we're applying on the technical front to this world is what it's really doing. It's not taking away jobs from doctors or taking away jobs from my claims processing team. It's letting them shift their focus from the huge barrage of stuff that's low value and could be automated to the small set of things where you can really do something significant. And from the doctor's standpoint, it lets them put a lot more attention into the cases where they need to really apply their differential knowledge.
But wouldn't that shrink the amount of work they do that's available for them to do?
I don't see it. It lets them apply more work exactly where it's needed.
And probably focus
rather
more
than
on-
having to peanut butter spread their attention across all this work going on, whether it's in your day-to-day operations or whether it's a doctor thinking about the patients they've got in hand. It lets them spend their time focusing where it's
So we'll still pay for 50,000 radiologists and all the computer technology.
One thing I want to touch on that John said, John mentioned the point about how it's impolite to talk about lowering the cost of healthcare because it means everybody in the healthcare system makes less money. There's some truth to that, but I don't think it's a zero-sum game, that there's only winners and losers and there's a fixed amount in the pie. Actually, if you reduce costs in the right way by putting the patient in charge of the healthcare dollars again, a lot of what is the fat in the system is middlemen and women and also wasteful utilization that comes from the fact that the patient is so disconnected from the value and price and quality of the care they're receiving. So I actually think the bank shot really is to put more consumers in control of those healthcare dollars, to buy the insurance that's right for them, and to watch the entire system respond. You know, we talk about a patient-centered healthcare system in America all the time. Well, you're never going to have a patient-centered healthcare system if the patient doesn't control the dollars. The moment the patient controls the dollars, you watch. We will have a patient-centered healthcare system.
But only if you have the transparency so the patient knows what to do with the dollars.
You know, we don't have to have a law to require price transparency for
Right.
airfares because we're paying for them directly, and every airline knows that if they don't advertise their price, we won't buy their airfares. You know, if you go to Toronto, right, Canada, socialized medicine, blah, 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 you will see on billboards the price advertisement for LASIK surgery. Why? Because LASIK is not covered by the Canadian health insurance plan. So it works just like any other product or service in the economy. So the more we can move to that patient-centered health insurance market, I guarantee you all that stuff like transparency will automatically happen.
Let me just ask, just 30 seconds each real quickly. We're at the edge of another iteration in the healthcare debate, healthcare policy debate. And I'm interested in something that all of you seem to be very committed to is keeping a substantial number of Americans covered, more in the future than are now. Most of the criticisms beyond things like existing, pre-existing conditions and other factors is the issue of whether 24 million Americans might drop out by 2026. And I'm interested in how you would handicap this right now. Do you think that we will see a resolution of the debate, Avik, that keeps more Americans tilting towards more coverage, or do you think, given the way you're all astute observers, we're going to end up with a system with far less coverage in America?
Yeah, very much the former. That's my hope. I think when we talk about that 24 million number, that comes from the Congressional Budget Office, which is putting an enormous amount of weight in the individual mandate in the ACA. They believe that repealing the individual mandate alone will lead to 18 million fewer people having coverage in 2026 relative to what the ACA would do by then. That number seems high to me and a lot of other nonpartisan economists. So I actually think that if the Senate bill shape plays out the way I hope it will, that we will end up, in 5 years if we're back at this conference saying, you know what, the Republicans somehow managed to pass something that actually leads to more people having health insurance than have it today. And it'll be interesting. You've had a Democratic bill passed on a party line vote, a Republican bill on a party line vote. Maybe after that we can have bipartisan health care discussions.
Alan, real quick.
I've got very mixed emotions about the individual mandate. We need to have a balanced risk pool for this whole system to work. You cannot pay for the very high-end costs for the patients that have something catastrophic happen unless you've got everyone contributing into the pool. So whether it's with the CSRs and benefits coming in to help low income, or whether it's with a mandate, we need the full population involved in the system for it to be spread out and able to operate.
Audrey?
Yeah, I hope what Avik says is right. I don't see it myself, but so I think that I'm concerned that there will be a significant loss in the number of insured through federal health reform, but I think states are just going to have to get a lot more creative about how they can maintain some of the coverage that will be lost at the federal level.
Thank you. John, last word.
Well, there's, if you want to balance risk pool, it's either an individual mandate or sufficient subsidies to make insurance really, really appealing to people who are pretty healthy. We have enough money in the system to do that. The Republicans are, in Congress, are torn between actually trying to retain coverage for the 20 million or so and giving that money back to their constituency. I think they're an impossible bind. If they actually do health reform that keeps people insured, they won't have the money to do the tax reform that they really want to do.
Fascinating. You must be fun at dinner. You're so optimistic. Let me open up this question. Yes, questions. One right here. Yes, sir. Third row. Hi.
Hi. This is something.
Tell us who you are.
This is something that from both the left and the right refuse to talk about, and it's a hot potato. But some level of tort reform.
Tort reform.
Yes.
All right, tort reform. Thoughts, Avik?
There is actually a bill to do tort reform for people in the Medicare and Medicaid programs that is in Congress right now. One of the big debates on the right about tort reform is whether, because it's normally the province of the states, whether constitutionally the federal government has a role in regulating the way tort litigation proceeds. But it's something that you hear a lot about in kind of the intra-Republican debate about health reform.
Terrific,
So
right here.
People are talking about it.
Thank you.
Kevin Laughlin, I'm a urologic surgeon. The issue about, it seems to me that we're at a watershed moment as a country, and that is we're either going to have universal single payer coverage, or we're going to have some permutation of two-level health care. And the issue, and in fact, the ACA really was 14.5 of the 20 million who were covered were Medicaid.
Right.
So essentially that's what we did. But in terms of transparency, to me, that's fool's gold unless we have competition. It's like saying...
Got to be real short here.
Okay, JetBlue, if they give me their price and I know what it's due to, I need to have other options. Why can't we have insurance companies going across state lines, and why can't we empower some patients with a patient savings account when they can shop and decide where they're going to spend their money?
Thank you. Real short form. Avik, you've been in favor of savings accounts.
Competition is so important. You know, let's talk about Partners Healthcare, which basically owns almost every hospital in Massachusetts. When that merger happened between MGH and Brigham and Women's, that was the biggest driver of health and care inflation in Massachusetts. That's what we got to break up. We've got to really do a lot on antitrust and other things to stop hospital consolidation from getting worse.
Alan, Audrey, John, we have like 30 seconds, so.
I agree on the competition side. The cross-state, I'm a poor geek. I don't really understand how that's going to help me because we still have to go out and work with hospital systems and deal with contracts and so forth and get good negotiated in-network rates. And how that moves, I don't know.
Audrey?
Yeah, I worry about cross-state if essential benefits are an option, because I think you could have other states coming in and selling, plans selling really cheap products that then destroy your risk pool.
Snake oil salesman. John, last word.
I am troubled by the ahistorical nature of this entire discussion.
Uh-oh.
Getting from here to
You are
there.
history. You're our history moment here, though.
Well, I actually have a degree in history, and getting from here, the trick is how do you take your current situation and evolve it within the value and political structure of the United States to something that's better, and going in any of the directions.
So railroad tracks matter.
Yeah, I mean, you can't just simply turn around and go 90 degrees the other way. I think historically, we'd be much more likely to do Medicare for all over time with a left-wing government than we are to get to Avik's a vision as nice and pretty as it is.
John, thank you for checking off that history box. I appreciate it. Please give a round of applause to John Kingsdale, Audrey Shelto, Alan Warren, and Avik Roy. Thank you all very, very much.
Thank you.